So cardiac disorders. Basically, the way I'm going to break it up is like this. All right. Overview. Heart failure. Now, we did a lot of heart failure already in, I think, chapter 6, but we're going to go into more in depth now. Okay. Then we're going to get into coronary artery disease and talk about myocardial infarction. We're going to go into heavy details about this because this is the #1 killer in America. So you can bet that on the NCLEX and all your exams, they will have tons of questions on this. You might as well start making your cards or writing your notes and stuff and building up on that because they will ask you a ton of questions on this. Okay? Then we'll get into heart valvular diseases. We'll talk about stenosis and regurgitation. Okay? A little bit of endocarditis and rheumatic fever. Diseases of the myocardium. We'll talk about cardiomyopathies. People are born with later on, if they were born with a certain disease of the heart, the myocardium, then later on there's things that happen. We'll get into those. Pericardial diseases, not so much on that, maybe like 2 or 3 slides on that. Congenital heart disease, that's the part that you definitely need to know the fetal circulation. So we're going to try and finish up all of this on Wednesday, which means that you need to know about fetal circulation on here. And then we'll get into arrhythmias, which is irregular heartbeats and stuff. Okay? So that's basically what we're going to do. My goal today is just to do the heart failure. Okay? And a lot of that could be reviewed for you.
The heart is a pump which must circulate blood through 2 different but interconnected vascular systems. The smaller of these systems is the pulmonary system. Blood returning from the upper part of the body is delivered to the right atrium of the heart by the superior vena cava, one of the body's 2 largest veins, while blood returning from the lower part of the body is delivered to the right atrium by the other major vein, the inferior vena cava. Contraction of the right atrium in each cardiac cycle forces blood into the right ventricle. This is followed by contraction of the right ventricle, which pumps blood into the pulmonary artery, sending it on through the blood vessels of the lungs. As the right ventricle contracts and pressure within the right ventricle rises, the tricuspid valve situated at the opening between the right atrium and right ventricle shuts, preventing any backflow. The pressure generated by contraction of the right ventricle soon opens the pulmonary valve and blood enters the circulation of the lungs. After passing through the circulation of the lungs, the blood, having been recharged with oxygen and having rid itself of carbon dioxide, is returned through the pulmonary veins to the left atrium. The left atrium, too, contracts, forwarding blood into the left ventricle in order to fill it before it contracts. As the powerful left ventricle contracts, the mitral valve shuts, preventing backflow into the left atrium. The aortic valve opens and blood is forced into the aorta, which distributes it to the rest of the body apart from the lungs. As the contraction comes to an end and pressure in the aorta falls, the aortic valve snaps shut to prevent backflow into the left ventricle.
All right, but before we go into there, let's just look at a big picture here and understand how we can figure out heart disease. All right? Heart failure is the ability or the inability of the heart to perfuse all the organs. Now, what causes that? Well, you need to understand what features or what components do you need to pump the heart. So these are the 4 components that pump the heart. You need to have a good blood supply to the heart itself, right? The coronary arteries, right? To the heart muscle itself. You got to have valves. Remember, valves ensure one-way blood flow. So if this is a valve over here, let's say this is your left atrium and here's your left ventricle. There's a valve here. The blood is going to go this way. Open up the valve. The blood will move from the left atrium to the left ventricle, and the valve will close. And now blood can't go backwards. That's what a valve is, okay? We're going to later on talk about valvular diseases where it might just open a little bit. That's going to cause problems. Or it's going to open, but then it's going to flop backwards. So there's going to be a backflow of blood, all right? So we'll get into those later on. But we got to make sure there's a one-way blood flow. So we got to have heart valves too. We also need to have a good heart muscle. You don't want something that's very weak. We got to have a good heart muscle. And how do those muscles actually contract? Well, we have to have electrical stimulation, right? We've got to have some kind of action potentials going on in there. So, and that's where the SA node and the AV node all comes in. So we need to have these four things. Now, if you understand about these four things from A and P, then we could go into the details about what causes disease, because what the diseases are is when any of this gets malfunctioned. That's basically it. All right? What they are, well, we have a lot of different diseases that would do this, but it's one way of seeing. I kind of organize things for you for hematology. Try and break up things, okay, into, these are what's causing the heart to pump. Well, then, what happens when something goes wrong? If there's no oxygen, let's say the coronary artery gets clogged. That's going to cause heart failure. So any of these things, if they get interrupted, will cause some kind of heart failure, okay? So let's talk about heart failure now. So ejection fraction. You guys know about ejection fraction from A&P 2, right? You can learn about ejection fraction? All right, here's a rundown about it, all right? These are all slides I took from my A&P 2, that's what I mean. So ejection fraction is the amount done in that cardiac cycle, okay? What it is the percentage of blood when you have a full left ventricle, how much of that blood is going to go out. So we have a formula, stroke volume divided by the end diastolic volume. So end diastolic volume, diastole, means when the heart is rested, right? It's relaxed. When you fill up the heart, it has to be relaxed. When I take a balloon and I want to blow it up with air from my mouth, I can't have someone contracting or pressing on it as I'm getting air in there. It's not going to happen. I got to make sure that it's relaxed. No one's pressing on the balloon. Same way here. You can't have a heart contract and fill at the same time. It won't work. So when it's relaxed, you could distend that part or the cavity as much as possible with that because there's nothing contracting it. So at the end of diastole, that chamber is going to be filled. Does that make sense? So end diastolic volume is when the heart ventricle, in that case the chamber, left ventricle, is filled. The stroke volume is the amount of blood after one squeeze or one contraction, how much of that blood comes out. Now here's a little tip for you. It's never 100%. There's always some blood that's residual in there. Most of the time it's like 20 or 30% that stays in that left ventricle. It's just the way that it works. So what an ejection fraction is the percentage of that blood that's in a full chamber. How much of that comes out, percentage-wise? So what we're trying to say is that in most cases, and I'll just give you numbers, let's say after you fill up the left ventricle, maybe 100 milliliters is there. I'm just giving you numbers. But let's say it's 100 milliliters. When the heart squeezes and you've got a stroke volume of 70 milliliters, then that's telling you the stroke volume is 70. The full chamber is going to be 100, so the ejection fraction is 70%. Right? You see how you get it? Now, these numbers are important. A normal ejection fraction is anywhere from 55 to 70%. If you have less than 40% or equal to it, that's the definition of heart failure. How do you get these numbers? How do you measure this? Well, that's what an echocardiogram is, an ultrasound of the heart. They could actually measure what it looks like, how much blood is in there when it's empty, or let's say when it's end of systole, and they could actually see how much is there at the end of diastole. And they can figure out when you just subtract it. You've got a stroke volume. Okay? So that's how we could define if the person has heart failure. Okay? Does that make sense? Okay? So that's the injection. We'll be using that term quite often here. All right, well, we have two types of heart failures. All right? Well, in terms of diastole and systole. Systolic heart failure. This is when systole, this is when the heart contracts and it's not contracting well. It's contracting very poorly. So we say this is heart failure during systole, because it can't contract properly. So if the ventricle contracts or improperly, it's not going to push out a lot of blood. Does that make sense? Right? Try not to memorize at this point. Understand what's happening. Visualize that chamber and see what happens when it doesn't squeeze that well. If you have 100 milliliters in there, we'll make easy numbers, 100 milliliters, and normally 70 shoots out, that's your stroke volume. But now it's weak, only, let's say, I don't know, 20% come out. Now you got an ejection fraction of 20%. See what I'm saying? All right? So the ventricle fills properly, but there's a decrease in the ejection fraction. Right? The chamber, the left ventricle fills, but it has 100 milliliters, but very little comes out. This is mostly due to coronary artery disease, CAD, myocardial infarction, and cardiomyopathy, which we'll talk about on Wednesday, all these different things. So that's a systolic heart failure. We also have a diastolic heart failure. In this way, it's trying to squeeze, but it's filling, but the chamber is a lot small. It's smaller because perhaps the thickness of. Let me do it this way so you can see this. All right, so I'm only going to draw one side of the heart. Okay, this is the left atrium. This is the left ventricle, and this is the aorta. You see how I drew it? Yeah? Just one side of the heart. What valve would be here? Which one? That's the aortic valve. Good. What valve is here? The bicuspid or the mitral, right? Tricuspid's on the other side. Okay? Now, if normally we have a chamber that's this thick in the left ventricle, that's okay. That's normal. But what happens if our ventricle is now this thick? We still fill this. It's still full. And it could still squeeze, but there's a smaller amount of blood coming out because the chamber is smaller. Does that make sense? Mm-hmm. Okay? Now, the ventricle could be, when it gets thicker like this, we say that it's hypertrophies, or it's hypertrophy. And hypertension will do this. So let's go backwards a little bit. Before I did this, why would hypertension cause the heart to become thicker? All right, we got to go back to coronary artery disease, or not coronary, let's say atherosclerosis. If there's going to be this blood vessel, let's say the aorta, becomes thicker, because we are now making this atherosclerotic. We're putting fat in here. Okay? That's going to increase resistance as the blood goes through there because it's narrower, right? That's going to cause high blood pressure, hypertension, right? You increase resistance, blood pressure goes up. Now this heart needs to squeeze blood into the aorta, but it has resistance there. So what's going to happen is this has to squeeze harder to get the blood through there. Does that make sense? And what you're doing is you're like lifting weights. You're trying to lift more and more weights. You're trying to push more and more blood through that narrow passageway. And every time you lift up weights, what happens to your muscle here? It gets thicker, right? So that's what's going to happen over here. The muscle is going to get thicker. We call that hypertrophy. So we could have high blood pressure causing hypertrophy in the left ventricle. Does that make sense? Which makes the chamber smaller. So now you can't fill that much blood in here because the chamber is so much thicker. That would cause diastolic heart failure. Does that make sense? Are you putting this all together? Okay. That's why you got to visualize this physiology here. The names you just have to memorize, all the diseases. But if you understand the concept, then you can say, well, what's going on here? Okay? All right. So this is systolic heart failure. In other words, this muscle here, it's pretty thin, so it's going to have a hard time trying to squeeze the blood out. It's very poor. Whereas over here, diastolic, the muscle is very thick. It has no problems pushing the blood out. The only thing is the chamber is much smaller. So it's, as it fills during diastole, it's filling, but less blood in there. So we say that it's diastolic heart failure. Does that make sense? Okay? All right. Now, I promise you, we're going to be doing valvular disorders later on, but we need to, I just have to talk about it very briefly about certain things, because when we deal with heart failure, it won't make sense to you. But we'll go into the details about it later on. So let's talk about stenosis first. All right, whether mitral stenosis or aortic stenosis, we'll talk about those later. But the word stenosis means that the valve is not opening properly. It's difficult. Remember, the valve is like this. This is the left atrium. This is the left ventricle. This is the mitral valve, or bicuspid valve, right? Normally, it goes up like, opens like this. Blood pours through. As that gets filled and the pressure gets stronger down there, this will just go like this and close. Open, close, right? One-way blood flow. The blood is not going to go backwards. But in a stenotic valve, let's say mitral stenosis, for some reason, it's calcified on the valve itself, and it's not opening properly. It doesn't go all the way open. It just opens maybe that much. So it's narrow. Stenotic means, or stenosis is a narrow opening. So now it's going to take a longer amount of time to get blood into the other chamber, or the other chamber is just not going to get that much blood in. Okay, does that make sense what stenosis is? Then we have something called regurgitation. We could also call it insufficiency or incompetence. So mitral insufficiency, mitral incompetence, mitral regurgitation. What this is saying is that the valve doesn't close properly. This one doesn't open properly, this one doesn't close properly. So this, again, we'll go to our picture, or my arms. Here's the mitral valve. Normally it goes like this, and then close. This, and close. In regurgitation, this, and then flops that way. See it? Now blood is going backwards. That's not good either, because now the left atrium has to pump more blood to get in there. It's kind of circulating the same amount of blood. Okay? Does that make sense? So that's regurgitation versus stenosis. We'll be using those words. Now, just a couple of things just to add over here, which we'll talk about later, is that the treatment for valvular disorders is usually valve replacements. Okay? We'll get into those later. And because these valves are dysfunctional, they're more like a magnet, so to say, for streptococcus. Streptococcus, when it gets into your bloodstream, it goes to where at least the antibodies will go to where the valves are, and it starts putting vegetations on there, and it causes even bigger problems. We'll get into those later. But anybody who has any kind of dental procedures or certain medical or surgical procedures, they need to get, and they have a valvular disorder, whether mitral stenosis or mitral valve prolapse, they have to be given prophylactic antibiotics to prevent this disease, which is called endocarditis, from happening on the valves. All right? Who here has heard that certain people need to get certain antibiotics during just getting cavities out or putting them in, right? You've heard about this. Okay. So we'll get more into that later on. Okay. So congestive heart failure, right? We did this before. Now, we really call it heart failure. Old school, they like to use congestive heart failure, but I want you to understand that heart failure doesn't necessarily have to be congested, all right? But a lot of people use it interchangeably. Congestive heart failure and heart failure meaning the same thing. There's two types. There's left heart failure, and that's more common than there is right heart failure, all right? And there's two broad causes of congestive heart failure, all right, or heart failure for that matter. It's either the workload is too much, or the muscle is just failed, doesn't work anymore. Okay? So that's what I'm saying. Keep an eye on these two things, and then there's a lot of diseases that will fall into this or this. If it does, it's going to cause heart failure. Put it together like that. So left heart failure. It's due to one of those two things, right? Increase the workload. Hypertension, as I just showed you over here. Hypertension is going to increase the workload of this, and eventually it's just not going to be able to push anymore, and that's what's going to happen. Mitral or aortic regurgitation, because the fluid is going to go back into the left ventricle, and now the heart has to push more to get in there, or get it out. Aortic stenosis, right? If this is stenosed over here, the heart has to push harder to get it through that little hole, right? It's all making sense. Put it all together, okay? And congenital heart disease, again, we'll get into those when we talk about the fetal circulation model. So we could increase the workload that could cause left heart failure, or just muscle failure. And the number one reason for left heart failure is coronary artery disease, right? Heart attack, right? That kind of thing, where the coronary artery just gets blocked with all the atherosclerosis, all right? You can have multiple heart attacks. Because what happens here is that you could have, remember what myocardial infarction is. Infarction is necrosis. So tissue dies. So you'll have dead tissue here, you have dead tissue here, you have dead tissue here, you have dead tissue here. You have too many of this heart is not going to be able to pump because there's a lot of dead tissue there. It's not going to pump properly. And that can lead to left heart failure. Okay? And then we'll get into cardiomyopathies later, more like usually genetic diseases of the heart. We'll get into those later. All right, so we did this before, right? This is a similar picture. It's the same picture I showed you before, but now let's go through it again so that you understand it, now that we got all about the heart. So this is left heart failure. For some reason, that left heart is not pumping blood forward. All right, and this is important that you need to understand, like I showed that little video before, you need to know the blood flow through the heart. Otherwise, you'll be lost on it. For some reason, that left ventricle is not pumping blood properly. So what happens to the cardiac output? Increase or decrease? Decrease. What happens to your blood pressure? Decrease. Okay? So there's less perfusion to all your tissues throughout your whole body, including the kidney. Well, the kidney has a wonderful job. It's going to pick and understand that there is a decrease in blood pressure. So the kidney gets smart about this and says, whoa, we got too little blood flow going to the kidney. I'm going to release a certain chemical out of the kidney. What is that? That's going to raise blood pressure. That hormone. Renin. The only thing is, this is always going to be low blood pressure because the heart is not pumping properly. So the kidney gets smart and says, well, I'm just going to give you a whole potload of renin. So the renin overshoots to try and, it's a compensation. It's trying to compensate to get the blood pressure back up. Every time it's going down, well, the kidney says, we got to get it right back up. So it overshoots and produces a lot of renin, and people with left heart failure tend to have high blood pressure because the amount of renin that comes out of the kidney. Okay? So you don't see the low blood pressure. The kidney senses it, but you never see it because the kidney is just producing so much of this renin. Now let's go back to the heart. Because the left heart can't push the blood forward into the aorta, a decrease in cardiac output, the left ventricle fills up with blood. Now, the left atrium can't push its blood into the left ventricle because it's already occupied with that large amount of blood. So now the left atrium gets backed up with blood. And then the pulmonary veins start getting backed up with blood. And then eventually goes into what organ? The lungs. And now the lungs are backed up with blood. So now you're going to start, where the blood vessels are in the lungs, as you learned before, start seeping out. So So now you get pulmonary edema. And you're going to have problems breathing, right? You're going to see all the symptoms will start making sense to you. Okay? So questions about that? Now, if that happens even more, if it stays long-standing, this left heart failure, and the lungs get congested, then it's going to get backed up further. And then what part of the heart is then going to get affected? The right ventricle, right? Right, the pulmonary arteries, which get backed up into the right ventricle. So now there's, similar to what I had over here, but let's say this is reversed. Let's say this is the right side. So this will be the pulmonary artery, this will be the right ventricle, this will be the right atrium. So if the blood gets pushed, so you're going to have pulmonary hypertension. Does that make sense? So now, it's the same picture you saw before. The right ventricle is trying to squeeze the blood into the lungs, but it can't because there's pulmonary hypertension. So then what happens to the thickness of the wall of the right ventricle? It gets thicker. And then you're going to have right. So from left heart failure, if it's long-standing, it can lead to right heart failure. Okay? Does that make sense? Again, you need to know the blood flow through the heart, otherwise none of this makes sense. Okay? Making sense, though? Liking it? Right? Okay. So, these are symptoms, signs and symptoms of left heart failure. Again, you might have to memorize the words, but it should make all sense to you if you understand left heart failure. I'm not going to go through them all, but you'll have shortness of breath, dyspnea, right? You also get orthopnea, which is basically shortness of breath while lying down. Big thing. It's not a big thing. It's just, you know what I mean? It's the same thing. You have also a paroxysmal nocturnal dyspnea, and that's the same thing as this one. The only thing different is that as you're lying down and sleeping, you start waking up in the middle of the night because you can't breathe. It's the same thing. All right? Tachypnea, which basically because you're basically drowning in all your fluids, the pulmonary edema, you start hyperventilating. And that's what's happening over here. Tachycardia, because the heart is trying to pump faster to get the blood to increase the cardiac output, which you can't do. Right? You get cyanosis. Cyan is a color of blue. So you see blue lips. Why? Because the cardiac output would decrease. You can't perfuse the lips. You can't perfuse the fingers. So things start turning blue. Okay? You get all these other things. Also on chest x-ray, you get an enlarged cardiac shadow. Fancy word for the heart looks bigger. Okay? Because it is. If you're increasing this muscle mass, well, the muscle mass is getting bigger, the heart's going to look bigger. Okay? And you'll get prominent pulmonary veins. That makes sense if you understand the blood flow through the heart. The pulmonary veins are going to be congested with blood coming from the left atrium. Okay? So complications of left heart failure. Hypoxia, that makes sense, right? Low oxygen throughout your whole body. You get respiratory acidosis. Remember we were talking about you increase your carbon dioxide, reaction goes the other way, and your acid goes right, your hydrogens go up, right? Right. You get arrhythmias, which are irregular heartbeats. We'll talk about those later. Decreased renal blood flow, right? Well, that's just part of it, but basically a decrease of cardiac output, you're going to have less blood flow going to the kidney, okay? And it could, like I said, it could lead to right heart failure. All right? Is this making all sense to you guys? Right? All right, so let's talk about right heart failure. And we'll call it right heart failure. All right, it's due. Keep in mind, we're talking about the two things, right? We're going to deal with increase the workload or something wrong with a muscle is not working properly. The number one reason for right heart failure is left heart failure. Long-standing left heart failure will eventually get backed up, and go into the right heart. And now there's too much pulmonary hypertension that the right heart has to pump harder. You got pulmonary hypertension. That could just be from the lungs itself. Okay. Tricuspid or pulmonary valve disease. Again, we'll talk about those, but you can understand if they're stenotic or if there's regurgitation going on. And congenital heart disease. Muscle failure, again, if there is heart attacks going on, multiple heart attacks, the same way as the left heart side would do. Now there's something else called cor pulmonale. Cor pulmonale is it's rare that would happen, but it's any right heart failure that the cause is solely from the lungs. All right, pulmonale, like lungs, right, pulmonology. So it's not from a heart attack, it's not from CAD, it's not from anything but from a pulmonary source. Okay, and we sometimes refer to it as cor pulmonale. Okay. So let's just do this picture. And what happens here is, for some reason, the right heart, the right ventricle, is not pushing blood into the lungs. For whatever reason, heart attack, or pulmonale, whatever. So if it can't push blood into the lungs, how much is there going to be decreased or increased blood going to the left atrium? Less. What about going to the left ventricle? Less. What about into the aorta? What happens to cardiac output? Decrease. What happens to your blood pressure? It's decreasing, right? But there's less blood flow going to the kidney. So what happens to the kidney? What is it going to spit out? Rennet. So what happens to blood pressure? Goes up. So in both left and right heart failure, you get high blood pressure, hypertension, because there's a decrease in cardiac output, and the kidney is trying to compensate by spitting out a whole potload of rennet. Okay, does that make sense? Now, let's go back to the right heart. Since it can't push the blood forward into the lungs, the left ventricle is going to fill up with blood. That means there's a backup of blood into the right atrium. And then you've got the superior and inferior vena cava, right? Does that make sense? But because we have gravity playing on us, the inferior vena cava is the one that's going to fill up with blood first in terms of backflow of blood, right? It's different, I guess, with high blood pressure in bats, because they sleep with upside down. But we're not dealing with bats, okay? But we walk around, this is what happens. So what happens is that the feet are going to get swelled up first with edema. The blood is going to, not the blood, but the plasma is going to go out, right? So it goes to the feet, goes to the ankles, goes to the shins, and you have that pitting edema. Severe cases, you can have pitting edema in the thighs, you can have the pitting edema in the hips. And then it starts going in your abdomen. You're going to have a lot of extra fluid that's going to pour out of there, and when it does pour into the peritoneal cavity, what do we call that? Starts with an A. Ends with ascites. Oh, yeah, see, I thought everyone knew it. Ascites, right? So that's what happens over there. The liver and the spleen get engorged with all this backup of blood. So the liver is going to get enlarged. The spleen is going to get enlarged. All right? That's later on, you know, when it gets more severe. It starts at the toes and works its way up. Okay? So you could have what we call hepatosplenomegaly, meaning like the liver and the spleen enlarged. It might just be the liver, but we talked about those before. It'll keep on going up that way. Eventually, you could also have fluid that's pouring out into the lungs, because if you remember with this, if it goes after the inferior vena cava, the superior vena cava starts getting a backup of blood, right, gravity-wise. And what we also see, too, is, let me go to this thing, jugular venous distension. If a person's lying on their back, all right, and you can see this when you get into the hospital, they're lying on their back, and not all the way down, usually on a 45-degree angle. You'll see their jugular veins start throbbing. They're distended. This is telling me that they have very high blood pressure, because it's all filled up over here, and now it's starting to get into the superior vena cava, or the branches lead into the superior vena cava, and you start seeing these jugular veins start being distended. the pressure, the jugular venous pressure increases, causing the distension in the jugular veins. So that's what's going on over there. We don't see much of shortness of breath if it's solely right heart failure, because there is nothing going on inside the lungs. Does that make sense? Right? If it's left heart failure leading to right heart failure, yes. If it's cor pulmonale, yes. You see what I'm saying? Okay? So like I said, you get edema in the feet and legs, the genitals, pitting edemas could go high. You got the liver and the spleen both being enlarged. And like I said, effusions could happen in the thorax, we call that hydrothorax, in the pleural cavity, or if it's in the peritoneal cavity, we then call it ascites.